Hi, and welcome to the Behavioral Health News Spotlight and Excellence interview series, where we feature exceptional leaders and innovative healthcare solutions that are raising the standards of care in the behavioral health community. My name is David Minot, and I am the Executive Director of Mental Health News Education, the nonprofit organization that publishes behavioral health news and autism spectrum news. Our mission is devoted to improving lives and the delivery of care for people living with mental health conditions, substance use disorder, and autism, and supporting their families and the professional communities that serve them. Today, we're speaking with Jihoon Kim, CEO at InUnity Alliance, which was founded in 2023 from the merger of two long-standing organizations, the Coalition for Behavioral Health and the Alcoholism and Substance Abuse Providers of New York. InUnity Alliance is a leading voice for all New Yorkers living with addiction and mental health conditions, their loved ones, and service providers, offering advocacy, training, and education, while working collaboratively with a robust network of diverse partners and its membership of 250 addiction and mental health care providers statewide. Leading our interview is Dr. George Petit, founder and CEO of Quality Healthcare Solutions. George is a community psychiatrist leading the behavioral health sector to innovate and transform healthcare for those most in need and vulnerable, including people with intellectual and developmental disabilities, those struggling with mental health and substance use challenges, individuals in poverty facing eviction or homelessness, and all those marginalized, unemployed, and disadvantaged. George is also a board member of Mental Health News Education. I'm excited to learn more about InUnity Alliance and its impact on behavioral health in New York State. George, the mic is all yours.
Great. Thank you, David, and good afternoon, Jihoon. I'm so excited to have this opportunity to talk with you today. Having worked for decades in the New York City health and behavioral healthcare sector and collaborated with the two prior organizations that recently merged to become InUnity Alliance, I'm really looking forward to what the newly appointed CEO is thinking and planning. So first question, can you share with us a little bit your strategic vision and priorities for InUnity Alliance in your first year, especially as it relates to and how we're going to address this growing mental health and addiction crisis in New York?
Sure. Thank you, George, and it's great to be here. First, I'll say that our strategic vision and our priorities, in the first year, but also in the upcoming years, are always going to be rooted in the everyday experiences of our membership, the communities that they serve, and the people who are receiving services from the community-based organizations. So as David said in the intro, InUnity Alliance came about as the merger of two longstanding associations. And now we, have a statewide association representing 250 community-based organizations that are providing addiction and mental health services. And I've been spending a lot of my recent weeks and months traveling the state, and just completed a tour actually in Western New York, Finger Lakes, the North Country, and the Capital Region, and have plans to spend more time also in New York City, Long Island, and Central New York and the Southern Tier. I think in my time in government, one of the most important things was not to legislate or dictate or regulate from the Capitol and the halls of Albany. It was really to meet people where they are, including the people who are receiving services as well as the people who deliver those services. And in my short time here, it's been 4 months exactly to date. The main issues that I'm hearing over and over again about are inadequate reimbursement rates, the historic workforce challenges, especially in the human services and mental health sectors, and also stigma and the disparities that exist. And when I talk about stigma, it's not just stigma about the people who receive services, but it's rooted in that. It also exists in the layers of bureaucracy that exist between government organizations, insurance companies, and the like, right? I think there's a disparity between how we look at the services and the providers that deliver the services in addiction and mental health care versus, big H healthcare. One of the challenges that I experienced in government that I'm hearing a lot about from my members is about citing issues, citing OTPs, citing other clinics. I don't think you would actually have those same kinds of issues if you were going into a community and to legislators and talking about bringing an urgent care clinic or a hospital into a community, right? So why is there a disparity in how my members are being treated by government and others as it relates to their services? So those are some issues that, impact the daily lives of New Yorkers who are trying to access addiction or mental health care services. And it's, deeply rooted in stigma that, we've overcome a lot of it, but I do believe there's still a lot more work to do. I think the other thing, George, is that we have to define the problem and talk about it honestly, right? I think one of the things that I've been spending a lot of time doing in traveling the state is meeting with providers across the continuum of care as it relates to the overdose crisis, right? And I think what I'm hearing over and over again, regardless of what part of the state I am in, is that people are genuinely concerned, providers are genuinely concerned about a lot of government officials who seem to have taken their finger off the panic button as it relates to overdoses. I think the CDC came out with provisional overdose numbers not too long ago. And, I've heard many leaders in healthcare talking about it like, the things that the policy changes, investments over the last couple of years have worked. Whereas I would argue the opposite. I would argue that, over 6,000 deaths in New York State, 2 years in a row. One example, Western New York, the Buffalo area is on pace to exceed their numbers from the last 2 years. They're projected to have over 400 overdoses in this year. Those are unacceptable numbers. Fentanyl is actually the leading cause of death amongst any category right now, any category. And you layer that on top of the overdose rates in New York, while they, at a statewide level, have ticked down very, very little, according to the latest CDC numbers, it still is like the sixth leading cause of death if you calculate it in the top 10 leading causes of death historically, just behind strokes, I believe. So, I think those overdose numbers are unacceptable, especially as it relates to people of color, particularly men, Black men, and especially those over the age of 55. Those numbers are rising sharply. I think you have to always look at the data in full context, not just the top lines. And those are the realities, right? I mean, you can also make the same argument as it relates to suicide numbers. Suicide rates and kind of analyzing those rates have been around for a long, long time. And we are seeing suicide numbers not being abated by all of the investments that are being made at a national and at a state level. And we have to ask the question, why is that the case, right? I think it's because ultimately we have to be honest about the facts on the ground so that government officials will not continue to use their facts or their sets of facts to deprioritize addiction and mental health services under the guise of tight budgets. And I think one of the most important things is that we're using data honestly to say, there's an existing system of care within addiction and mental health where you have a continuum of services offered by community-based providers who have been talking about, underfunding for quite a long time, actually since deinstitutionalization. They have been arguing about the need for more investments into community-based providers. And, I certainly think that when I talk about traveling the state and starting where my members are and the people that they serve, that connects directly to the information that we're sharing with people in positions of power who actually can make policy changes and make the right strategic investments into the providers who are doing the really difficult work day in and day out. And I have a couple of other points on this topic. I have a lot to say about this. Third, I think one of the strategies is that really grateful for the work that both John Coppola, formerly of ASAP, and Amy Doran, formerly of the Coalition for Behavioral Health, have done really to merge the two organizations. Not everyone goes down this road of mergers because it's not easy, it's not difficult. And I think everyone ultimately wants to ensure that the priorities of whatever agencies that are merging are both retained in the new organization. And they both have done tremendous work, including with the respective boards. And I appreciate all of what they have done and their guidance over the last 4 months. They did actually end their terms as consultants, beginning July. And I'm excited to say that I'm building a strong team here. Sarah Duvall started as our policy director in early June, and we have Amanda Semity coming in as our chief operating officer next week. So that's part of my strategy, is that we're going to build a dream team here at InUnity Alliance, where we are not only providing expert services and technical assistance to our members, but we're thinking about how the work that we're doing with our membership, relates to the kind of policy and advocacy we have to do at a statewide and a national level. And then finally, I will say, George, I think my background for your audience that may not be familiar with my most recent background in government. I had the privilege of serving Governor Kathy Hochul as the deputy secretary, overseeing all of the mental hygiene and human services agencies, including OMH and OASIS, OPW, and others. And I believe that my lengthy history in government and the most recent position I had, directly overseeing the state's investments and policy decisions on addiction and mental health services, can really empowers InUnity Alliance, where I can advise and empower the entire InUnity Alliance membership, based on my deep understanding of the players and politics that inform decisions in Albany and also in City Hall here in New York City. So that's my long-winded answer.
Great. Thank you for that. It's super exciting, and congratulations on your 4-month anniversary and your recent hires. I do think, this does fill me with a lot of sort of excitement and hope, because, the leveraging the power that each of these organizations, had in their own right and coming together, but also with your experience in government, I do think there is sort of this opportunity. We're at this sort of inflection point in really being able to enhance the advocacy and the sort of the steering some of those public dollars in a more sort of, data-driven way. I love that you're talking about data and really trying to hone in our capability to be able to address these issues, not in this sort of global fashion where I think, historically we've done, a little bit of everything everywhere, but really focusing in on those communities that are most impacted, whether it's, targeting the issues you brought up around, older Black men and, overdose deaths, or some of the rising rates of suicidality among LGBT, and all these other sort of disparities that exist. Like, how do you think about, or how are you planning on, really advocating for more of a common sense approach to funding and procurement based on data, and then not being driven by, some of the mechanisms that have currently existed?
Yeah, I mean, that's a great question. I think, it's interesting. And I think this, you can kind of go either way with the strategy here, right? I think ultimately when you're thinking about, just focusing on New York state government for a second, when you're thinking about state government and state investments, there are always more priorities that a governor and their fiscal people will inherit and have to manage and deal with, then there are dollars to go around. That's just the reality. I think it really boils down to helping to reprioritize how government should be looking at the broader behavioral health sector, given what we know on the ground is happening as it relates to overdose rates, as it relates to suicidality and suicide completion, especially as it pertains to particular groups. I think there's always this risk, and I saw this, and I admit, I think my time in government, there's always this desire or kind of a knee-jerk reaction that you want to announce something flashy, that you think everyone's going to be like, great. What I learned in my time in government, including being one of the main architects of the governor's $1 billion investment in mental health 2 years ago, was that there's an existing infrastructure of providers. And I can pick a handful, I can just pick out of a hat the membership of InUnity Alliance. Small, large, very diverse, very focused on one population, where there are experts who have been doing this work forever. So I think really what it boils down to is listening to the voices of the people on the ground, not only from my perspective as the new CEO of InUnity Alliance, as I get to learn my membership and really what their priorities are, but also for government officials to say, hey, listen, you really do need to listen to people on the ground, right? I think this happened within the healthcare system during COVID, where you had a lot of healthcare establishments saying, hey, you really need to listen to us, government, as they're like, we're the experts. We know what works in our communities. You really need to help us figure out and organize around the fact that communities across New York State, with all of its beautiful diversity, there's a lot of common ground in what we know works, right? And I think what we know works is community-based care, right? That is very low threshold, meaning there are very little barriers, whether that's insurance barriers, payment barriers, whatever the barriers there are, that exist, and really investing in those services. And InUnity Alliance is made up of many member organizations that really deliver services where people are in their communities. And what I've seen and what is beautiful about the community-based kind of network is that you'll have an organization in the Bronx that says, hey, we started off providing medication-assisted treatment, and we have an Article 31 mental health clinic. What we realized with a lot of the people coming through our doors is we have lots of rates of folks who don't have a place to live. So we need to open a shelter, or we need to open some kind of other transitional living kind of program. We also recognize that a lot of people have unmet healthcare needs. So we have members that actually have FQHCs and other whole suites of services that really meet the people where they are. So what I would say is, we know what the data is showing, even with the governor's investments over the last 2.5 years in mental health, and the opioid settlement dollars actually going out the door over the last 2 years. We still see numbers that reflect that there's historic underinvestment in the existing infrastructure of community-based providers that actually better serve the needs of the average New Yorker who has unmet needs. Yes, there are people who are going to need to go inpatient for a period of time sometimes. There are people who may need an inpatient level of stay for addiction. But generally speaking, much as it is with broader healthcare services, people do not stay hospitalized inpatient in some of those more costly settings for the duration of their recovery. And when we're talking about mental health disorders, and substance use disorders, we know that for the most part, people will need some level of services for the rest of their lives. And in that case, it makes the most sense to invest in the community-based system of care.
Yeah, no, I fully agree. And, as you were talking, I was thinking about a couple of, follow-up questions. One of them, you talk about the voice of the community-based providers. And having been on that side, but also in government side, I do think sometimes, we're not necessarily talking, with each other. We're talking maybe at each other. And I think that, being able to sort of bridge some of that between, community-based providers and government, I think is really critical. But one thing that I have, sort of come to realize, and I think it's really critical that we try to figure out how do we elevate the voice of the individual served. I think that there are initiatives underway, and there are, different organizations and different settings and where the voice of the individual served might have a larger, valence. But I do think that, sitting in government, we sometimes don't really think about, the impact of what we say or do, or even community-based providers coming up with their strategic plan for the next, let's say, 3 years, without really bringing into the conversation those individuals served, whether they're in a supportive housing unit or in a CCBHC or in a peer recovery program. So I do think we have to figure out, and this is it's not a question, it's more sort of, a rhetorical framing, but, I do think we need to figure out how do we elevate those voices differently. And I'm hoping that InUnity Alliance will, think about that as it's moving forward in terms of how do we embrace, some of those voices. So, anyway, so just a quick pivot then in terms of thinking about, the where we are today, status post COVID and all of the issues that have come out of, the lockdown and the workforce crisis. And I think, when I was, at a large not-for-profit organization, our biggest, issue was workforce, right? High turnover rates, low wages, recruitment and retention were really complicated. And we're all, the $1 billion that, the governor put in our, in the budget actually ultimately translates into programs which require individuals to be hired, whether it's a nurse or a social worker or a doc, and everyone is scrambling to find those resources. So from the perspective of InUnity Alliance, what are your thoughts about where and how you can mobilize the community-based providers around thinking about initiatives or programmatic ways of addressing some of those issues related to, recruitment and retention of workers in our sector?
Yeah, I mean, where I always start with, as it relates to the conversation about the workforce, is also rooted in my own experiences. I, worked as a direct care worker in a nonprofit with men with both mental health disorders and intellectual and developmental disabilities. And this really feels like it was ages ago, but I still say to this day, in any job interview I've had, because I've worked in this field for a while, including in government, this is like the portfolio that I always had. Is that it was my favorite job because there was like the direct, tangible impact on the lives of individuals that you can see every single day when you went to work, right? But I also say, as part of that story, I always had aspirations to go to graduate school. It ended up being in social work, and it was impossible for me to balance going to grad school, having to have another internship in grad school, and keeping that job. I wish I could have done it all, but I couldn't. And I think about it in hindsight because, if I were to stay at that organization or a similar organization, I probably would have had to work 3 or 4 different jobs. And what would have probably happened is I probably would have worked my way up through like an administrative kind of position within the organization, right? And in many ways, I would have left like the lower wages job behind in an interest to just be able to pay the bills. I think about this a lot too, because as I was in government, there were lots of stakeholders coming to me asking for increased wages. And ultimately, the turnover rates, the workforce crisis, it is directly related to historic underinvesting in this field. And recognizing that kind of the nominal cost of living adjustments that, depending on the whims of that political year, that budget year, would either make it into the budget or not make it into the budget. That's not a reliable source of revenue for organizations that have to do multi-year planning as it relates to their services. Very complicated services in many cases. So the turnover rates are directly related to underpaid, low wage employees, and but it's not the only. It's not only about wages, but that is one of the main reasons why jobs that already lead to high burnout results in high turnover. The wages are just simply inadequate, George. So we need to raise the wages of the entire industry. And people are literally leaving these jobs for other higher paying low wage jobs and working multiple of them. I mean, there are ideas such as developing like true career ladders for direct care staff, whether it be through mentorship or training programs so that they can grow and promote within the organization. But, that also does leads to potentially the ranks of middle and upper management, being taken care of, while there will continue to be this challenge with the lower paid jobs, right? Which is, I think, the bulk of the jobs in most of these organizations. And even loan forgiveness opportunities, those are, to the large extent, it really is to help people, on a career path within the organization, and growing, going up the career ladder. I do think that there are some initiatives underway, right? There are some initiatives underway, whether it's in the IDD sector or, other sectors where, there are some incentives being offered to the nonprofit sector. There's currently, a push for a bill to expand the existing like government pension benefits to the nonprofit industry, particularly in this field. That's something that Mahaney's has been leading the effort on, and it's something that InUnity Alliance supports. I think there are ways that, and now that I am the CEO of my own nonprofit organization, I recognize that there are ways, even within a limited budget, for you to be able to take care of employees, keep them happy, keep them motivated, especially in these very high stress jobs. I think there are those kinds of incentives. I think one of the things that is also, I think, lost within the conversation about workforce is what an organization, I mean, related to what I was just saying, but what an organization can actually do internally to help the workforce. I think supervision is often something that is not talked about that often. I'll give you an example of how, recently I've been meeting with a lot of organizations that have begun to have been trying to expand their use of peers. And the peer model is something that is not new, but has been growing as of late. And I am proud that InUnity Alliance one of the things that we continue to do as part of the merger and with the work that ASAP was doing is continuing to expand upon the peer certification and recognizing that, we have SERPAs, we have the Certified Recovery Peer Advocates, but we also have been developing other certifications, including a peer supervision professional credential, really with the goal of supervising and supporting this critical workforce. I think that's a good model and example of other types of support that employees that are in very high stress jobs where they probably would leave for another job that is paying similar or a little more, that's not in the same kind of field, to make sure that they're supported, especially with their high level of stress. And I think also relatedly, George, people, providers do need to build in systems of care for their employees, right? Including like enhanced and flexible paid time off policies, as well as, other management strategies to engage the employees, all things that we're also thinking about internally for InUnity Alliance staff. But I think overall, to wrap it up, I think there are internal strategies that can be employed that only go so far, to be quite honest. I think ultimately it comes back to what is InUnity Alliance going to do with our really effectively doubling the size of our membership with the merger, in advocating with a very loud but also strategic voice as it relates to the sector. And when we're talking about the workforce, it's to help government officials reprioritize all the priorities. I know that, with all of the priorities that lay before any governor or any budget director, they're going to look at potentially, with our sector, like giving us what remains after negotiating internally what all their other priorities are. I think that's unacceptable. I think we need to reframe the problem statement so that people understand, especially, and I know with this governor, she cares deeply about, issues related to mental health and addiction, but it's really helping them to reprioritize how that should be, in like the tier A level of investments that they're thinking about, to make sure that the existing community-based system of care is robustly supported, not only with investments, but any, beneficial policy changes.
Yeah, no, that's super important. But related, I was thinking as you were talking, thinking about how do we shore up sort of just the foundational underpinning of how we're paying, our staff, especially our direct service providers. And I keep on thinking about the fact that, if you're trying to create career ladders and build in supervision, peer monitoring and supervision and coaching to be able to ultimately help individuals, stay within their trajectory and actually move on. Those aren't reimbursable services. So I do think that's sort of a little bit larger. It's like, how do we think about, the fact that we've got so many healthcare plans? I mean, luckily now, parity around commercial rates, still not great, but in terms of the rate itself. But, how do we sort of figure out a way of working, from your perspective, from where you sit, in terms of really pushing the envelope around what or how managed care organizations need to work more collaboratively and meaningfully with providers, and not just the providers per se, but as you were building out, the state has built out these, constructs of independent practice associations, some of them clinically integrated, that want to have, contracts with managed care on behalf of their membership. How do we get them to start paying attention to those issues, which are really critical for the entire sector?
Yeah, that's a great question. I think ultimately, it's something that I started off in the opening question. One of the things I hear most about from members are about inadequate reimbursement rates, right? And I think that's directly related to your question about, ensuring that there are these kinds of strategic partnerships where, we're not just pointing the finger at each other, right? I mean, trust me, I'm very familiar with a lot of the finger pointing that happens as it relates to insurance companies and then community-based organizations. And, I mean, kudos goes to the New York State Council for their work, really elevating the issue of the inadequate rates on the commercial insurance side, right? I think, what was passed and what was enacted in the recent budget, thanks to the work of our sister organization, Provider Association, is that there is a requirement that commercial insurance companies pay at least Medicaid rate as a floor, for the outpatient OMH and OASIS licensed services starting next year. And, that in and of itself is historic, right? I think when you couple that with, and this is where, I don't know how much people understand, what network adequacy, what network adequacy looks like within behavioral health outside of folks who work in behavioral health care. But the insurance companies understand what it looks like, right? They do. They certainly understand what it looks like. From my time in government, I know this firsthand that they fully acknowledge and recognize that there are inadequate networks as it relates to the addiction and mental health, clinics. And the other thing that is coupled with the Medicaid rate as a floor for commercial insurance is regulations regarding network adequacy requirements that will really help to ensure that insurance companies are negotiating in good faith with community-based organizations and like psychiatrists and others who are really like, they look at the commercial reimbursement rates and why would they go in network, right? Like they can even just their going rate, which is reasonable to begin with, is far above what commercial insurance reimburses. So the question that I started asking in my time in government is, why would a psychiatrist go in network? It's like deplorable, the rate. So like, what incentive can we provide? So in addition to the Medicaid rate as a floor, for a lot of these outpatient OMH and OASIS licensed services, there are going to be new network adequacy requirements where if an insured, an enrollee, cannot find an in-network provider within 10 days, that the insurance company has to actually pay, allow that person to go out of network and pay the in-network rate. I think when you think about the economics of it, what we hoped, from my time in government, what we had hoped that would do, and we still have to see if it plays out this way, coupled with the better parity on the reimbursement rate, is that they will negotiate in good faith with these clinicians to try to get more of them in network so that they can have adequate networks where they're reimbursing at something that is at least on par with Medicaid. George, I mean, I don't think it's lost on you as someone who's run an organization that delivers services. Talking about the Medicaid rate as the floor, honestly, it should shock people. When you talk to the person who says, hey, Jihoon, you were deputy secretary. My kid cannot find a psychiatrist. Can you help me? What I always end up doing, I feel powerless in many of those conversations. And that's happening now as the CEO of InUnity Alliance, where ultimately I have to go through the whole process with them. Who is your insurance carrier? What is your in-network benefit coverage for your plan? And kind of going through all of that. Have you tried finding someone within your network and all of that? Ultimately, what it amounts to is that there are these prohibitive kind of floors established throughout, any enrollee's insurance coverage, where, quite frankly, at the end of the day, when someone needs help, especially for mental health or addiction services, they're not going to find someone in network. That's just the reality. So I think that's one important issue. I mean, we have a long, standing, existing relationship both through the coalition and ASAP, where we have a strategic partnership and a good relationship with the Health Plan Association. And I think ultimately, at the end of the day, we've had these conversations with them, since I've joined InUnity Alliance, where it's really continuing the conversation for me from my time in government, where we need to better partner on these issues. I don't want to finger point here, but I want to make it very clear what the realities are for New Yorkers who are trying to access services. And when they have health insurance, they wonder why they still cannot find, coverage. And a lot of that is related to reimbursement rates. And when providers are not being reimbursed adequate rates, then they're not going to be able to, reduce those wait lists. And it really is incumbent on both the community-based providers, but also the insurance companies to ensure that we're working in partnership so that we can really solve this problem for all New Yorkers.
Yeah, it does resonate deeply with me in terms of, the complexity of this, and that I do think we've got an incredibly inequitable system of care where access to services is not affordable, timely, or even meaningfully accessible in any reasonable way. And I have similar issues where people will call me, constantly about trying to find psychiatric care for their loved ones, and it shouldn't be this complicated. It shouldn't require, you or me or some others to have to figure out where and how to connect people to services. But sort of sticking with that idea in terms of equity, the 1115 waiver, we're working on it. We have these, the NOFA went out for the social determinant of care networks and the whole waivers based on creating health equity. Where and how do you think InUnity is going to fit into some of the thinking, the planning, the strategy, the implementation of some of those initiatives to try to ultimately get us to be a bit more equitable in how folks access services? What are your thoughts about that?
Sure. No, I appreciate that. The 1115 waiver is huge, right? And it's the hot topic for many providers and experts serving different populations throughout New York. And I worked on part of that in my time in government. I didn't work directly in the healthcare side of things, but I think there are opportunities within InUnity Alliance that we've already been providing for a lot of our members. We've provided free webinars as well as learning collaboratives for InUnity Alliance members directly as it relates to the 1115 waiver. And we're going to continue to develop strategic partnerships. As I know that the SCN announcement was delayed a little bit towards I think the end of the summer, early fall. But we have been in contact with many different organizations that have applied for that, so that we can actually leverage those relationships as well as the opportunities built into the SCN model. But I think the other thing that's not getting as much attention for some reason, but is equally, or if not more exciting, are all the workforce dollars that are available through the 1115 waiver. So I think there's an opportunity there where we're going to continue to work in close partnership with a lot of organizations throughout New York State who have already reached out, because there are many organizations that are very excited about what's happening with the merger to create InUnity Alliance, and people have reached out to set up time to talk about 1115 and potentially partnering, given InUnity's broad membership of addiction and mental health providers throughout New York State. I think one of the things that I will say, because there's always good news and bad news with anything, right? One of the things that I was very disappointed not to see in the 1115 waiver was the part that would provide Medicaid services to incarcerated individuals prior to their release, right? We understand that there is currently, a process that the state has kind of developed in partnership with some community-based organizations and advocacy organizations to get this reprioritized. In InUnity Alliance, we are also thinking of other ways that we can keep the attention on this issue, because we know for a fact that our jails and prisons, for many New Yorkers, especially those living in poverty, especially those who have been part of marginalized groups historically, that they become the de facto service delivery system, unfortunately, right? So it's unconscionable that Medicaid has to turn off and then turn back on, where we know that within 72 hours of release, especially for someone who is on medication-assisted treatment or in recovery for an SUD, that they're at the most vulnerable state, right? So that is no time to lose. I think we are hopeful, and we will continue to advocate for the state to actually, include and submit that part of the waiver that was left out of the last waiver. And there's some more news to come about that, George, but we will, save that for a future date.
Yes.
But yes, I think the 1115 it provides a lot of opportunities, and it's actually a good example of places where we can partner closely with folks outside of traditional mental health and addiction organizations, where we're thinking about the whole system of care for an individual.
Yeah. Yeah, no, that's great. Thank you for that response. As I'm thinking about, the waiver and then all these different sectors that we talked about, and partnerships. I mean, you mentioned partnerships multiple times. I do think, again, so we're at this sort of potentially unprecedented time where our ability to be able to really foster partnerships that are meaningful, because I do think that, not every one of your members can do everything for everyone in their community. So how do we bring, the different components of this healthcare ecosystem, which is incredibly rich and diverse in New York, together to really sort of, I think, all be rowing in the same direction. What I encountered and what I have experienced is that, everyone is so, head down, nose to, to the grind, so trying to just keep themselves afloat without really thinking about, how do we partner up differently with other community-based providers, using platforms like yours, for city and state, which are its own two separate issues, right? But city and state government, all the different stakeholders, and all of the non-traditional, non-medical, providers are going to hopefully be part of the the waiver in terms of thinking about the SCNs. And then one other piece that I don't think that we really do a good job at including is all of the private, sort of the private entities that exist. I mean, whether we like them or not, they're there. They're for profit, but they actually do exist, and they are competing against us in terms of some of our, from the not-for-profit perspective, from our workforce. So how do we bring everyone together in some meaningful way to really think about how do we address all of these issues that we've been talking about, collaboratively, in partnership, comprehensively, so that we're not all, I feel sometimes we're all spinning our wheels. I don't know if that's even a question, but what are your thoughts about?
But no, you raise a good point. I think this kind of goes back to when we're advocating, right? I think there are some kind of bread and butter policy advocacy issues, and they all boil down to the survival of the nonprofit sector, the survival of community-based organizations. You're right. People put their head down, they work hard. Some have more of a cushion in their fiscal budget, in the fiscal year budgets, so they can do some innovative things. Many are not even at a place where they can even contemplate how does AI and all these tech evolving and emerging technological advancements, how can they even incorporate that, because they're so worried day to day about their workforce, having enough people doing direct care work and paying their bills and keeping their doors open, right? I think ultimately this all ties into advocacy, because when you think about it, everyone is so worried about their piece of the pie, right? And I understand why. This is normal when you're just used to not being prioritized by government, right? And it's not even prioritized in the sense of give us billions of dollars, don't ask questions, just give us money. That's not. I think sometimes that's how government looks at community-based organizations, but that's not what it is. Some of it is about policy flexibilities and regulatory relief. But I think ultimately we have an advocacy agenda where whether you are a not-for-profit, a for-profit, whether the issue we're advocating for is maybe 2% from your business perspective, of a concern to you, or if it's 80% of a concern to you based on what your portfolio looks like, we have the opportunity as InUnity Alliance to advocate for everyone's needs as if all 250 organizations were all saying the same thing. That's the beauty of the advocacy world and the association world, is that not only do we allow somebody to not have to be the one having that difficult conversation with a state agency commissioner or their office or the governor's office or DOB for fear that there might be some kind of reprisal. Not that people are vindictive and are going to do things like that, but there is always that fear. We don't want to stick our necks out on this. We have an advocacy organization in InUnity Alliance that can do that for you. If I could give you one example of a way that this kind of concept really played out well with the restoration of some cuts that were in the enacted budget. We advocated strenuously throughout the budget negotiation process and then post-budget enactment, state budget enactment, for the restoration of $11.4 million in vocational and educational services and programs that OASIS had, that the governor's budget had included as cuts in the OASIS budget. And I think from an InUnity Alliance membership perspective, I think it impacted maybe 5 to 10% of our members at most. But we, as an association, did a call for a letter writing campaign, phone calls, and advocacy, where ultimately the state did something unprecedented. And they actually, with something that was in the enacted budget, $11.4 million in cuts, it was actually 8.4 because the legislature restored 3 million of it. They restored the entire program post-budget enactment, which honestly is unheard of. In all my years in state government, that never happened. But to me, not only am I proud of that advocacy, but I think two things. One, that's a good example of where we had the entire membership get very motivated, because I think everyone saw this could be us. This could be that program that's kind of on the margins of people even being aware of what it does and how it benefits people in recovery from an addiction, that we can be next. And I think we kind of hit on the nerve of people's concerns, which also leads to that. Put your head down, work very hard, keep your business open, provide services, let someone else advocate for us. We don't have time for that. Also, to give our members insight into what happens when you put all of your advocacy together under the umbrella of an advocacy organization to say, this is unacceptable. We're in the middle of an overdose epidemic, and you're cutting services that help people in recovery. So I think that's a good example. And I know that I didn't directly answer some other parts of that question, but you're right. I think we're in this part, we're at this critical moment where everyone recognizes, especially coming out of COVID, that there was this kind of sleeping pandemic of unmet mental health and SUD needs, and it really emerged to the surface where now it feels like a lot of people are scrambling to try to throw spaghetti at the wall and see what sticks. But it's not time for us to get competitive. I think it really boils down to you start where the person is, and what I will say is whether it's InUnity Alliance or an association that serves people with IDD, an association that serves people primarily in the foster care system, we're actually talking about the same people. And I think at the association level, we've recognized that. So we're going to partner very closely with a lot of our like our sister and peer advocacy organizations to really unite forces in this upcoming budget, because we realize that what we cannot show is any kind of competitiveness in amongst associations, because we're all talking about the same people that our members serve, regardless of what kind of license you have from the state.
Yeah, no, that's super critical, and I'm glad to hear that, because I was just thinking as you were talking, the amount of stakeholder groups that are out there, or associations that represent sort of different parts of the sector, make it really difficult for, let's say larger organizations that have sort of varied portfolios to be able to really figure out how do you meaningfully lean into, InUnity or supportive housing or whatever it may be, right? So it's good to hear that you guys are thinking about, partnering up. You're right. I think what it comes down to is, we serve, in general, we serve some of the hardest to engage and treat individuals with complex care, multiple diagnoses, whether developmental disabilities, mental health, substance use, homelessness, all of the things that, really make this population so, vulnerable. So to really, have you keep your eye on the ball of that, this population that really needs folks to be very innovative and creative about where and how we're going to provide services in a very integrated, comprehensive, holistic manner. So you mentioned briefly, AI, and I can't not ask a question about sort of the influx of technology assisted care solutions, and where AI, whether it's machine learning or natural language processing or any of the big data analytic issues come into play. And I'm not even sure if you formulated your thinking around that, but like, where do you see InUnity having some level of influence around some of those technologies?
It's a timely question, not only because of everyone's talking about it, but because it's probably the one kind of group that has lobbied me for time on my calendar more in the last 4 months than any other group, and rightfully so. I think there are huge benefits. I think even in my time in government, it was like just emerging over the time that I worked in the governor's office, where you went from people questioning whether there were maybe like administrative efficiencies you can find for any organization, whether it was a community-based mental health provider or a for-profit company. There are actually ways to leverage technology, emerging technology, as including artificial intelligence, with training of the workforce, and providing other administrative efficiencies. I think there's a lot of benefit when it comes to those daily administrative tasks, tons of paperwork, where there are tremendous opportunities for not only cost savings for a nonprofit organization, but also to perhaps eliminate a lot of human error as it relates to administrative tasks. I think the trick, honestly, though, which is I think what more people are talking about, is not necessarily the administrative, like the business side of things. It's really what role does AI play in the actual delivery of services, right? That's a tricky one. The tricky one, I think telehealth was a good example of an efficiency that was necessary during COVID. And there are a lot of parallels that I think warrant being very intentional, and to some extent, I'm not saying like slow things down, but maybe some of it slow things down, because I think ultimately what I'm recognizing with a lot of the organizations that make up InUnity is they're not even at a place where they can potentially be thinking about, do I leverage AI into my business model and into my service delivery? Because the existing technology and infrastructure and billing systems needs and data collection needs of the behavioral health system has been lacking for a long time, right? I think it was never fully included when EHR was being launched on a broader healthcare level by the feds. So it's really, really lacking. So I think as I think about AI, as I think about maybe there are some members of InUnity Alliance, maybe there are folks within the behavioral health system and sector that can take advantage of it sooner rather than later, almost like in the sense of being guinea pigs in many ways. But I think there is huge potential. I do think that we should be very careful that we ensure it's person-centered, that we address any of the racial, ethnic, cultural disparities that always exist within technology and healthcare, and that ultimately it will be in the best interest of the people that InUnity Alliance members serve. I think if we could answer all of those questions in yes, 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 then I think it's the kind of thing that as an association we would be, trying to leverage and figure out how does this benefit our members. But I have I think a lot of people have more questions right now than answers. But I also know that there are some emerging technologies that have been around for a while, but are emerging to behavioral health providers that you'll see more and more and more incorporated into the business model over the next couple of years. And we're always looking to be kind of ahead of the curve, but on this one, I think it makes sense to be strategic as well as just watch and see what comes of it in many ways.
Well, that's a reasonable approach. I think there is just a lot out there, and it's important to be able to sift through that and figure out what might or might not be meaningfully relevant for providers and the people that we serve. But we've covered a lot of territory in this last hour. So again, thank you so much for joining us. I did want to see if there was anything that I haven't asked you or anything that you wanted to share that we haven't covered before we wrap up.
Yeah, I mean, what I will say, George, is I'm having a lot of fun, right? Like, it's weird. It feels weird to say that because anyone who knows me from my time in government, I mean, it was one of the highlights of my career, working for Governor Hochul as a deputy secretary. But it was also stressful in very, very different ways. I love the engagement with people on the ground, providing services to people in need, right? And I think ultimately any kind of government job, you just end up feeling detached from that reality, right? And I really thoroughly enjoyed the 4 months. Really learned a lot from Amy Dorn and John Capola, and grateful to them as InUnity Alliance continues to grow and plot out our kind of strategic vision and our plans for the next couple of years. And I really appreciate the time that that you've given me this morning. You and David have given me this morning to chat a little bit about our vision and what I think people can expect in the coming years.
Well, again, thank you so much for joining us. Wishing you tremendous luck. I mean, InUnity Alliance is a critical piece of our, healthcare ecosystem. So I'm really excited about all the things you're going to be doing with your team, and hopefully we'll be able to, check in again at some point down the road and see how things are going. But again, best of luck to you and congratulations on the role.
Thank you.
Yeah, and I echo what George said. It sounds like an amazing opportunity, and really looking forward to following where things go. So I'd like to thank you, Jihoon Kim, for sharing your time and expertise with us today, and also Dr. George Petit for leading this enlightening discussion. If you'd like to learn more about InUnity Alliance, please visit coalitionny.org and asapnys.org. And if you found this conversation valuable, I encourage you to visit behavioralhealthnews.org, where you'll find a wealth of information on important mental health and substance use disorder topics, including in-depth articles, resources, and more interviews with leaders in the field. You can also subscribe to receive our quarterly issues and stay informed about the latest developments in behavioral health. So once again, thank you all for joining us today, and stay tuned for our next installment of the Behavioral Health News Spotlight and Excellence interview series.